There we go. Okay. Good afternoon, good morning, good evening to wherever you're joining us from today. My name is Alan Dominguez, and on behalf of the International Dysphagia Diet Standardization Initiative, I'd like to welcome you all to today's webinar titled Thickened Liquids, the Good, the Bad, and the Evidence. It is my pleasure to have three wonderful panelists here with me today, Dr. Cicchero, Dr. Brookes, and Dr. Miles. Dr. Julie Cicchero is the past co-chair of IDDSI, and she will be moderating today's session. Just a quick housekeeping. The session is being recorded and it will be available on the IDDSI YouTube channel in the days to come. Anyone attending is in listen-only mode, so the panelists will not be able to hear or see you during the session, but we will have a short Q&A session at the end of the presentation. So you can submit your questions either via the chat function or the Q&A button on your screens, and we will try our best to go through as many questions as we can. But we want to be respectful of your time, so we'll have to keep them short and efficient. And Dr. Cicchero will do a great job at that. And lastly, we do not currently offer continuing education units, but a certificate of attendance will be emailed to everyone who is actively attending the session right now. So without further ado, it is my pleasure to introduce Dr. Julie Cicchero. Dr. Cicchero, go ahead.
Thank you very much, Alan, and welcome everyone. This is a very exciting webinar to start the year with, and I'm also very much looking forward to it. Just before we get started and I have the opportunity to briefly introduce our two wonderful speakers, I just wanted to provide some information and clarity, I guess, around IDDSI. So IDDSI is a standards organisation promoting the use of standardised terminology, definitions and testing methods globally to help improve swallowing safety for people of all ages, all care settings and all cultures. IDDSI does not endorse, certify or promote any particular product, service or practice. All right, so as I said, we are so terribly lucky to have both Laura and Anna presenting with us today to speak about an overview of thickened liquids in both adults and children and how the IDDSI flow test has benefited patients and providers. They're going to be discussing current practice and the benefits that they may offer some patients and potential disadvantages, and most importantly, critically appraise the evidence. Laura received her undergraduate degree from the University of Florida and her master's degree from the University of Virginia. She's been a speech-language pathologist since 1999 and has been board certified in swallowing disorders since 2012. She's a clinical specialist at the Children's Healthcare of Atlanta, working with pediatric patients in the intensive care units and adult care, acute care units. She specialises in the management of tracheostomy and ventilator-dependent patients. Anna is a practicing speech pathologist with 25 years of experience working in an acute and community setting, and as an associate professor at the University of Auckland, a researcher, lecturer and clinician in the area of voice and swallowing disorders. Both of our presenters are researchers, clinicians and have published widely. And without further ado, I'd like to turn the webinar over to them. Thank you.
Thank you very much, Julie. Just to acknowledge my thanks to Laura for doing this work with me, and just to say that this is a presentation that we have just done at the ASHA Boston Convention. So just if anyone was there, this is the presentation we did there, and we've been asked again to present it for IDDSI because it was well received. So as Julie said, our goal today is to look at the good things that thickened fluids offer us across the lifespan, some of the challenges of thickened fluids for our patients with dysphagia across the lifespan, and hopefully a balanced view of the role of thickened fluids in our practice. We do have some disclosures, as everyone does in life. So this is a hot topic, as people keep on telling me. It's a hot topic in the research realm, with large numbers of papers coming out on a regular basis at the moment, and a hot topic on social media with many blogs and commentary on the topic. And of course, it's also a hot topic because we have IDDSI amongst us, providing us with a considerably larger amount of stability, standardization, and support when it comes to the use of thick fluids in practice. And a larger number of companies providing us with their products to support our practice, and these are increasing every year. So thickened fluids, how do we use them? In the adult reign or the adult drinking style, we can thicken them. We can thicken our cold drinks, our hot drinks, our carbonated drinks, our fruit-based, our dairy, our water. And we do need to be careful with those products that as we change the drink, the viscosity will change, whatever the thickened fluid that we're using. And some of the products on the market are less vulnerable to that than they used to be. And there are lots of these pre-thickened drinks, like you can see on the screen, that don't involve us having to do the mixing ourselves, and we can buy the products already pre-thickened.
There are important age considerations for infants and children who are placed on thickened liquids. We have to pay attention to the manufacturer guidelines. Gel mix is recommended for infants 42 weeks post-menstrual age up to 12 months. Pure-Thick is recommended for children over the age of 1, and Pure-Thick can be added to cold or warm fluids. Thicken Easy and Thicken Up have both a clear gum-based option and also that starch-based option. And Thicket and Simply Thick are recommended for children 12 years and older. And if you are working with a patient and you would like to use a product under the recommended manufacturer guidelines, they just suggest that you check with the physician and get an order from the physician. And just a note that Simply Thick did change their age recommendations from 1 year to 12 years with the new Easy Mix. Thickening in the pediatric population also has a lot of challenges when it comes to breast milk or human milk. So amylase is the enzyme that is found in human milk, and it digests carbohydrates, particularly starches. There is 25 times more amylase in human milk compared to cow's milk formula. It is commonly believed that the amylase in breast milk breaks down cereals, so cereals cannot be used to thicken breast milk. And I have read that amylase inhibits the binding of the cereal to the breast milk, and so they're separated and unable to thicken. So we'll talk in a little bit about whether or not that is completely true. And there are also concerns about the impact of some thickeners on the immature digestive tract, particularly neck or necrotizing enterocolitis. There can be some possible side effects with certain thickeners, such as constipation, gas, or loose stools. And of course, with our patient population, we have to be conscientious about, how much things cost that we're recommending. And so sometimes these thickeners can be quite expensive for families. So thickening formula for infants does have challenges as well. So we know that there's an arsenic risk that is found in rice products. So the trend has been to move towards oatmeal cereals as opposed to rice cereals. There are options out on the market for lower arsenic content rice cereals, but the trend can be to go for the oatmeal cereals, and but some cereals they can be a little flakier and they can clog the syringe. So there are different tricks you can use to kind of grind the cereal before you add it to the formula. There's the formula mixtures that come already thickened, so the Infamil AR products like that, the anti-reflux products. Thanks to the IDDSI flow test, we can now test any thickened liquid or any thin or thickened liquid before we offer it to a baby, and now we know because of the IDDSI flow test that it actually is thicker than the regular formulas, and so it obviously thickens once it's inside the belly, but it starts out thickening as well, so it can be kind of a 2-for-1 for swallowing or reflux. And of course we can also use the commercial thickener gel mix for thickening formula as well as breast milk. Just something to note that the product thickens with heat and agitation. So you just want to make sure that that you're advising your families that the whatever fluid you're adding that to just has to be 98 to 100 degrees. Okay, and so these are just some of the ingredients in commercial thickeners that is just important to think about when you're talking to your patients and your families and your medical providers. So infants and children with dysphagia often have neurologic, gastrointestinal, anatomic, pulmonary comorbidities. So we just have to make sure that we're thinking about what all of these ingredients might have, how these might impact our patients. So for example, patients with short bowel syndrome, gastroschisis, omphalocele, where motility might be an issue, we might want to be more cautious when we're thickening liquids. Patients who are on a ketogenic diet need to restrict their carbs. So dietitians might be looking at the carb-fat ratio and talking to their dietitians and their physicians about what might make the most sense for their family. Maltodextrin is derived from wheat, corn, soy, or potato, so we need to be cautious of allergies as well. So when we're talking about thickened liquids, we've been talking about all the kind of challenges with thickening liquids, but you know, thickened liquids really have when you do a swallow study and a baby cannot safely swallow thin liquids, and you tried all the strategies and the strategies are not working, it is part of our toolkit. So it's something that might be the right move to keep the patient on an oral diet. So again, back to the IDDSI flow test, you know, we have all these challenges with thickeners because the base liquid, you know, can one thickener packet can thicken base fluids differently: orange juice, milk, water, thickener type, thickener brand, temperature, and time. So we have this solution, which is the IDDSI flow test, and I have this video. Anna, are you able to click on it? Oh, perfect. So this is, you know, we were asked, you know, can you do the IDDSI flow test with one hand? And this is my favorite bartender, Jordan, and she did this for us and demonstrated that sure enough, she can do the IDDSI flow test with just one hand and some creativity. Thickened liquids problem solving. So you have the flaky cereal that clogs the syringe. You can put the cereal in a Ziploc bag and grind it with a Coke can or a soup can. If there's concerns, people often have concerns about the thickened fluids clogging the bottle nipple, but you know, different products have the faster flows or the wide cut nipples. So these are all things you can test in a FEES or video fluoroscopic swallow studies to make sure that this is safely swallowed, that the combination matches what the patient can handle.
Love those videos, Laura.
Thank you. Okay, so this is a study that I just finished, and actually I'm so excited to get news this week that it was accepted for publication. So stay tuned for this. But it's looking at the effect of time and temperature and thickener on breast milk. So we talked earlier about how the amylase in breast milk breaks down starches. So I had really exciting results where fruit purees, bananas, peaches, pears, baby food, thickened breast milk and thickened, and it stayed the same thickness over time. Gel mix and pure thick were successfully thickened the breast milk. It did thicken over time. So that's just something to think about. Oatmeal thinned for cold and thickened for warmer. Vegetable purees were minimally effective. Squash was effective at cold temperatures, but the rest were not that effective. And then yogurt slightly thinned the breast milk, and pudding thinned very, very quickly. So the paper gets into a lot of the like food science and the molecules and why the enzymes and these different products you know, combined and stayed the same thickness or whether it thinned. So you'll have to read that to get more information. And so we want to just also think about the, problem solving, the cost and ingredients and access. We talk about social determinants of health. This is a study that inspired me to do the human milk study, where we use just common everyday purees, baby food purees added to water, yogurt added to milk, and we weren't trying to say that they were better than commercial thickeners, but they were certainly comparable. So we did the study I did it with a rheologist who had fancy equipment that can tell the shear rate, that can add, test the mixtures with the different shear rates of swallowing and different temperatures. And because they're all non-Newtonian, they all thin with swallowing and temperature, of course, but the easy, accessible food thickeners were very comparable to the commercial thickeners that we tested.
Such great work. I love what you've been doing. This is so important, isn't it?
Thank you.
So let's have a little look at why we do use thicken fluids. We've talked a little bit about how to thicken now. Obviously, one of the main reasons that we have thought about thick fluids from the beginning of time was that we are trying to keep our patients safe. And that makes sense. We know that dysphagia has an impact on pneumonia, mortality, length of stay in hospital. So, and if we think of stroke, for example, we keep people nil by mouth until they've been assessed by a speech therapist, because safety is our key, and we think avoiding aspiration is useful. But we do also now know that that's not the only thing we need to look at in life, and that risk of infection and respiratory complications is multifactorial. And while the aspiration is important, the immunosuppression of our patient is important, their mobility, their oral health. We've gained a lot more understanding about the more complex side to dysphagia care in recent years. But we do use thickened fluids for this aspiration reduction purpose. Laura, do you want to talk about that in pediatrics first?
Sure. We know that the thin liquids flow more quickly, and the thicker fluids are more cohesive, minimizing aspiration. And aspiration, when can cause instability for babies. Really medically complex babies, they can have bradycardia, desaturations, stridor, difficulty breathing, wheezing, pneumonia, respiratory issues. We know that there's a greater risk of silent aspiration in the infant population compared to adults, 90+%. I would say 99% of the patients I do video fluoroscopic swallow studies on, when they aspirate, they're not having a cough response. So these smaller babies, these more compliant airways, are at higher risk of obstruction with aspiration compared to us and our larger lungs. And one study showed that parents reported decreased apnea, decreased coughing, congestion, decreased aversion, emesis, and wheezing with thickened liquids. And then this other study showed that infants with silent aspiration who were on thickened liquids were the only population studied that had the reduced risk of acute respiratory illness.
One more for you, Laura.
Oh, sorry. Okay. I thought this was your.
I can't see each other's faces. That's the problem.
I'm so sorry. Thank you. So why do we thicken in pediatrics? So we worry about bronchiectasis, which we know is a very serious lung disease and irreversible. And so in this study, 63% of the subjects had an underlying disorder, and aspiration, as you see, is 10% of that. And severe pneumonia of bacterial and viral etiology were the most common disorders identified. So we want to, when we think about, is aspiration, it's just a little bit of aspiration, or it's breast milk, and does it really cause that much damage to the lungs? And any risk of bronchiectasis for these little babies and their tiny lungs is certainly something to consider.
And you.
And then I'll just go quickly. So obviously we talked about how when you thicken liquids, you can allow the baby to continue an oral diet, avoiding alternative sources of nutrition. You can avoid an NG tube, you can avoid a G tube, and we know that that can be actually associated with increased hospitalization. So NG and G tubes are not always the answer, and so if we can do something like thicken the liquids and allow the baby to continue to eat by mouth, then that's a win for everybody.
But perhaps in adults it's not quite so clear. We certainly get reduced speed of transit and more coherence with a thickened fluid, and with that, less aspiration. So we're getting control and potentially improved safety. In a study we did, and looking at a large number of endoscopic evaluations, you can see there that there's a significant reduction in aspiration with the smaller bolus size and the larger bolus size when we thicken the fluid. But perhaps when we think of that in adults, we'll come to that in a minute, the effect on the lung might not be quite so clear as in pediatrics. Laura, this is one of your cases. This is a great case to show.
Yeah, so this is a study that I did on a 2-year-old with she had a posterior fossa mass, and it was resected months ago. It was grade 4 medulloblastoma. We got the consult, and I was told by the team that she coughed with liquids. When I went into the room to do a bedside, mom said that she coughs with cold liquids, but not with room temperature, and she actually demonstrated that on the bedside as well. And given the risk of where the location of the tumor and the risk of potential dysphagia, we decided to do a video fluoroscopic swallow study. So you can just see here on the left, that's thin liquids. If Anna, you're able to start the video, so you can just see how quickly they are moving through the pharynx. And then in the middle is just showing that the material is reaching the level of the piriform sinuses before it's swallowed, which is extremely common in every video fluoroscopic swallow study I do on infants. I feel like, most of them trigger the piriforms as well. And on the right, you can just see that there's this slower flow, allowing the patient to time the swallow a little better, and they're triggering it a little earlier, allowing for her to protect her airway. And this is a nice example of that these are just options. Thickening is an option. This is a swallow study that I did on a colleague of mine. She said that her baby fatigue started to have difficulty maybe like 5 minutes into the feed. So we know from Dr. Kate McGrattan's study and Dr. Martin Harris and others that the first 30 seconds of the swallow study are not representative of infant feeding. So you can't get 30 seconds of a swallow of infant feeding and then turn off fluoro. You have to fatigue or turn fluoro off and turn it back on again. So we did that with this patient. We did all the strategies. We thickened, we did different flow rates, we did upright, we did sideline, we did all the things. And it turned out that under fluoro, thickened liquids looked better for her baby, but in life it wasn't. And so she chose to continue to thicken and to not thicken, and to just use breast milk and use as many strategies as possible, and use her close monitoring her that she, as a speech pathologist, that she could do for her baby, and we had a doctor support. And so it's just kind of underscoring that everything, it's not about us, it's not about our orders and our recipe. It's options, and that's what we do under fluoro, is we get options so that the patient can decide what's best for them.
One last one on pediatrics.
One last one is just paying attention to some of the literature out there from the GI doctors, that thickening actually, in this paper, if you want to look it up, it's just chock full of information on reflux. And they are tending, because milk is a base, and that we're leaning away from using PPIs for infants, not for children. Children, it falls a little bit sooner in the algorithm to trial a PPI, but for infants, the milk in their belly is actually not that acidic. So when it comes up, we're trying to reduce the acid in material that's not that acidic. So medications come with all their side effects. So that's been a current trend.
Great. So we've talked a little bit in pediatrics about pulmonary health. Let's have a little look at that further. So thick fluids, this is a tricky one. We've said that they reduce aspiration, but one of the things that a lot of us as clinicians have been concerned about is that perhaps we see some silent aspiration more often with our thickened fluids. And we did a study a while ago trying to unpick this, and just to be clear, it's the most impossible research in the world to do, this sort of clinical research where every patient's different and we're trying to control a FEES protocol. Anyone who does FEES knows that everyone you do is a completely different FEES to the next, so controlling for research is extraordinarily hard. So we took hundreds of FEES recordings and we had a look at the thin versus thick, and as I said, we could see that aspiration was reduced with the thick fluids. But when we actually just looked at silent aspiration, you can see here that we got an increased amount of silent aspiration with the thicker fluid than the thin. Now, this is a preliminary study. It definitely does not prove anything, but I think it makes a little bit of sense for some of us as clinicians. And from my doctoral study on silent aspiration and cough reflex testing, I can sort of come up with a theory around this. And just to be clear, it's just a theory. And that is that when we reduce the amount of aspiration, we're reducing the stimulus reaching the larynx, and therefore perhaps reducing the number of times we reach threshold that leads to a cough in patients, and potentially even the substance itself, instead of a cold, fast flowing water, potentially that smaller amount of more thick, sometimes room temperature thickened fluid that we use on the wards may be also not leading to that cough reflex. And I don't think this tells us anything about a must do, mustn't do, but I think it's something we should definitely be bearing in mind when we're practicing, that silent aspiration is not a label that someone either has or hasn't got. It is dependent on how much, what they're swallowing, what temperature it is. We need to bear a lot more in mind, and also think about the power of cough. That if we've got an adult that should have a cough response, unlike our infants, coughing could be good. And coughing as a response is good for clearance, but it's also a good sign for a patient that they need to do something. So I think this is really important and interesting information for us. I'm not the only person who thinks that. I see this come up on social media a lot, people finding silent aspiration on thick versus thin, and I think really important thing for us to bear in mind. And our lovely colleague Nolga also did this incredibly important preliminary animal study in rabbits, looking at injecting water, gum and starch into the larynxes of these rabbits and seeing how they reacted. And I'm just looking down at my notes so I get the data right. Only 12.5% of the rabbits that had cornstarch injected survived to the end point of the study, which was day 4, which I think is really interesting. The xanthan gum rabbits did survive, but there was mild hemorrhagic responses for them. And those that did survive, there was pulmonary inflammation and edema. Far more with the thickener than with water alone. So I think it's really important that we further research impact of thickener on the lung compared to water on the lung, particularly in view of our increasing information around free water protocols and the potential benefits of them. So again, something for clinicians to bear in mind quite carefully when you're making decisions with patients about what they might or might not want to choose as their recommendation. And then, as we started this presentation, the point that pneumonia is multifactorial, and therefore reducing aspiration or removing aspiration alone may not be enough to keep our patients, or may not be the only thing that keeps our patients safe. And that's probably why these sorts of studies that I've listed there struggle to provide us with pure, beautiful, high-level, statistically managed randomized control trials that absolutely say that we will reduce aspiration rates with thick versus thin. In fact, most commonly what our literature is telling us is that it doesn't make any difference at all, making it hard for us to have a clear, compelling argument with patients about why they should thicken their fluids. So again, it doesn't mean thick fluids can't be useful, but it does mean that there's an evidence base there that we need to be cognizant of ourselves, but also articulating with our patients. And this has become a huge part of researchers' work, trying to unpick this association one way or another. And there are large numbers of systematic reviews out there for clinicians to read. This paper looked at water protocols versus thick fluids on pneumonia, and they did a meta-analysis and showed no significant difference in pneumonia risk for thick versus thin. And there are a number of other studies looking in particular population groups, depending on the clinical area that you work in. And I strongly recommend you look at these systematic reviews. Systematic reviews are the quickest way of a clinician getting a large amount of literature absorbed, because they have done the hard work for you. They've looked at all the papers that are available, and they've analysed them together and interpreted them for you. The Hansen group have been slowly looking at this, and they're on their third publication on this topic, and many of you may know this work. So they did a second update of their first 2013 paper that came out last year. This is top 5% of all research outputs, tweeted and social media crazy on it. So it's definitely getting people reading it. And their conclusion was that there was no convincing evidence that thick fluids or texture modified diets prevented death or pneumonia or improved quality of life. Strong statements from the work that they did. But there are other people who have criticized that work a little, or have put some caution to it. We published something that's just come out in AJSLP, suggesting that while there's some merit in this work, we do need to be a little bit careful to critically appraise systematic reviews, as well as critically appraise scientific papers. And one of our critiques was that the reviews that they were updating weren't always looking at exactly the same topics and the same criteria, and that also they were sticking to the randomized controlled trials and excluding higher quality non-randomized controlled trials that perhaps offer us a little bit more of a mixed and clinically relevant focus. So just a warning that systematic reviews should also be critically appraised by you as clinicians. Here's another good example of somebody criticizing somebody else's systematic review. So this paper on the left came out last year, and they provided scientific evidence and summarized that they believed that there was a positive effect of thick fluids on hydration. But very fast came out a criticism in the journal from another group who said, hang on a minute, this is industry supported, and there's a bias here. And again, that they were not convinced by the choice of inclusion-exclusion criteria and the interpretation of that work. So no wonder we all want somebody to tell us what to do, because it's proving to be rather complicated. There are systematic reviews looking at stroke clinical guidelines that say that we're still using them despite the limited evidence base, and the list goes on, and I strongly recommend you keep a very close eye on what's going on to feel like you know what the literature's telling you. So let's just spend a few minutes looking at some of the reasons why thick fluids might not be useful for some of our patients. There are a number of papers, and this just came out last year, I think. This is a 2023 paper looking at the adverse effects of thick fluids, and we're just going to talk about some of the more relevant and interesting ones for us. The slowed transit. So what we have started to see is that while thick fluids may reduce aspiration, they do seem to increase residue, and they increase effort. So a level 3 IDDSI is going to take more effort to transfer than a level 1, and of course that's also going to vary depending on teat and bottle, as well as volume size, with increased residue in the mouth, pharynx, and esophagus. So if we're looking at that wheel of safety, efficiency, and quality of life, we're now starting to look at efficiency rather than safety. And we certainly see this in practice, don't we, that the residue with a thick fluid is, of course, sticking around a little bit more in the throat. I've got a real interest in the esophagus, and that residue that we see sitting around in the throat, we also see in the esophagus. And I know Julie's really interested in this area too, that reduced speed in the esophagus is not a good thing. We want things to transit through the esophagus quickly. Anyone who works in laryngology knows that we see this have repercussions altogether in our elderly with appetite and amount of food someone will eat, and in our gastro patients, chronic cough and globus and all sorts of things occurring because of esophageal symptoms. So if we give somebody something that's going to slow things down, we need to bear that in mind for their whole person, and look at whether that's an important factor for that patient. For example, in our Parkinson's patients, we don't want things to slow down too much because we don't want it to have an impact on their medicines. Some medicines are corrosive on the esophagus, and we don't want them hanging around too long. And some medicines will have their bioavailability and their drug dissolution affected by the slow transit or by the thickener themselves. And Julie's got an amazing paper on this if anyone wants to read about the release of a drug when put in a thickened fluid compared to when put in a water alone substance. Hugely important for us to be thinking of when we're working in geriatrics, where polypharmacy is such an important topic. And let's look at the third wheel of our safety, efficiency, and now quality of life, and what we really want for our patients. Laura, should we talk about children first, and then I'll move back to adults?
Sure. So we know, of course, similar to adults, that there is a taste and texture component. So while an infant might more reflexively eat thickened liquids and be fine with it, the older child, the pickier, more particular, I guess we shouldn't say picky, more particular toddler might have some opinions about what the taste and texture is going to be for their fluids. We talk about this, I talked about this earlier, of course, just how easy is it for a family to access the thickeners and what is it going to cost them? And then we talked about the variability in thickness, so we just always have to think about that. But with its deep flow tests and just either one syringe that, either the 2 syringe test or the 1 syringe test can tell you easily, if your combination is what you're looking for. And then we talked about just the impact on the immature digestive tract and these little babies, and just always making sure that we're looping in our GI doctors and our pediatricians and families, of course, first. But how comfortable are you with these substances on their little bellies?
We do know that adults also are not always keen on thick fluids, and some of them will not enjoy the taste, flavour, or the lack of thirst quenchingness of them. And with that, there is literature that suggests that there's reduced fluid intake and risk of dehydration with thickened fluids. Although that can be the case with thin fluids if they're too challenging and patients are avoiding them because they make them cough and choke. So we do need to be careful that there's a balancing act to be played there around fluid intake and comfort. There's a high burden on staff and family if we thicken fluids, and we know that that can in turn lead to less offering of drinks to our patients on the wards. This was a really interesting paper that asked patients whether they trade quality of life for years of life, and a huge number of them were willing to sacrifice years of life to not be restricted in their fluids. So a really compelling qualitative paper looking at whether we care about taking thick fluids or not. So with all of this in mind, I think it's really important that we think about the balance of evidence and the patient's specific needs. And there are most definitely benefits of thickening fluids for some, particularly in the short term, if aspiration reduction is an important prospect for that patient. But we need to be really careful that we are aware that there's no evidence of benefit for others, and not overusing them or underusing them or misusing them, or not reviewing them regularly. I regularly go into adult disability sector housing and find people on thick fluids that they haven't had reviewed for decades, and they've been decided to be put on a thick fluid in a younger age and not had that reviewed. And Laura's going to talk a little bit about weaning programs and how important they are.
Yeah, so...
sorry, do you want to say that now?
Yes. Sorry. Just a study that came out from Boston Children's introduced the idea of a thickening wean, which is just so important to underscore that thickening is a Band-Aid. It's a Band-Aid that sometimes is very effective, and we're so thankful for it. But the goal is thin liquids. The goal is to figure out why they can't swallow thin liquids safely, and why do they need the thickened liquids, and how we can get them down to the thin liquid as quickly and safely as possible. So the thickening wean paper was really, really helpful to get clinicians, especially outpatient clinicians, to help work towards this. The idea being that a slow, slight change in thickness and reduction in thickness over time the baby can kind of retrain or the child can retrain their swallowing. The only criticism of this paper, and that's in our references, is that they didn't follow up with instrumental swallow studies to show that it actually was effective. Sometimes the patient had to stall on the wean or go back to the thickened liquids because of respiratory stuff. So it's like we talked about earlier. It's a tool in your tool belt.
Yeah. And with the confusing evidence, we certainly need to be careful about informed consent and balancing risks in our patients, and maybe being clear with our patients, or certainly being clear with our patients when we recommend thick fluids, what we think they will do and what we're not sure whether they will do, not blanketly telling patients you must do this or it's going to definitely cause you a pneumonia, and making sure that patients can be part of that decision-making process. And there's a large amount coming out on that, as Julie suggested at the beginning. RCSLT, the Royal College in the UK, has started to publish some pretty clear evidence or statements of practice for their clinicians, including these statements. The literature reports that fluids can alter physiology and reduce aspiration. However, there is an absence of evidence that they reduce dysphagia-related complications such as respiratory infections, or that they improve quality of life outcomes. So some pretty strong statements from RCSLT, and they've just released their position statement on this that backs, I think, a policy or review of the literature to back up their statement. So again, talking about informed consent and a holistic approach being needed. Well worth a read. And again, lots more coming out on this topic of it being important that patients are the center, that they know the balanced risks for them, that we explore alternative treatment options, and that we ensure that we have instrumental assessment to back up our decisions. Laura.
And we can quickly go through this just because we definitely want some time for Q&A. But just when we think about ethics, we think about, doing good, doing no harm. Patients are, it's their choice to, they're free to choose. And then we want equality and fairness. So all the things that when we're working with our families, that we're thinking in the back of our head, thickened liquids is definitely, these are things to consider with thickened liquids. And we talked about social determinants of health too, and access and transportation. And just so I'm always thinking about what families' challenges can be, and then thinking outside the box and doing what works for the family.
I think you've talked about this one a bit already, haven't you, Laura?
Yeah.
The importance of it being always in the first point of call considered a temporary option that should be weaned from, and actively working towards a regular diet and fluids for every patient. And making sure that we also consider all the other evidence-based options that are available to us, or if not with large amounts of evidence base, at least physiologically sensible strategies that we've tested under instrumental assessment. We all know that we've got a large amount more in our toolbox than just thickening, and that we should look at positioning and bolus modifications, and ensuring that we're doing the best to give patients the most number of choices available to them to choose from. And we did it in 50 minutes.
Faster than Asha.
The hardest part of that was that I couldn't see you, so I didn't know when you were ready. I didn't have any social clues.
Well done, ladies. Thank you so much for a very informative presentation. I think you've highlighted a number of the challenges. I wanted to pick up on a couple of points, and then we have got some questions for you as well. So one of the things, and I've got my clinical hat on now, not my IDDSI hat, but my clinical hat, and just a reminder about pneumonia, and Susan Langmore's seminal paper from 1998 that talked about dysphagia not being sufficient in and of itself to cause aspiration pneumonia. So really making sure that we're aware of things like oral hygiene, dependence for feeding, dependence for oral care, all of those other factors. We are working in an incredibly complex area. And also to remind ourselves that this field is still only about 30 years young. We've actually got a lot more work to be doing in this really complex field. And I'm so excited that the two of you are contributing so strongly to the evidence.
I think
Okay,
you're right there, Julie. And I think the other thing that I see clinically a lot is, it's as I get more old, as I get older and I've worked more, I have less worry about it being my decision than when I was a junior clinician, and that developing pneumonia is not something a speech therapist, speech pathologist can be the only one making that call for a patient. We've already talked a lot about family and patient, but also the multidisciplinary team. We've got respiratory physicians who know a lot about that patient's vulnerability in their lung. We've got the neurologists and the general physicians and the geriatricians who know a lot about their overall complexity of their medical conditions and what their greatest concerns are. And we shouldn't feel we have to be the one making all those calls, because we don't have all the knowledge at hand about whether hydration is more important than respiratory safety, or, there's just too much there. And though we don't have that field in our hands, we need to work as a team.
We do. We absolutely do. And to your point earlier on as well about medications as well, our pharmacy colleagues are critical there. All right, I'll jump into these questions in the 8 minutes we have left. So one of the questions here is, some of the research has been done with water versus thickener and the adverse effects there, but just wondering about thin liquids other than water. So, looking at aspiration of, I'm ad-libbing here, but water or tea or coffee. Has there been any research looking at other types of thin liquids and their effects on lung health? And the person says, thank you for such a great talk.
Offhand, there is a study, and if there's a way to share our emails, you can email me. I don't know it offhand, but comparing the impact of water versus milk products, breast milk and formula, and then also your laryngeal response to those different substances. So what our pulmonologists say is that when people say, oh, well, it's just aspiration of breast milk, they say, well, breast milk has fat, and we don't want that in our baby's lungs. And so the only thing we want in our lungs is air. Obviously, there's a much more wiggle room with adults and choices and things like that. But that's kind of it's young. The field is young in adults, and Dr. Shakira, you know this because you work with adults and peds. It's younger in pediatrics. So if it's 30 years for adults, it's it's 15 for peds. So we have a lot more work to do. But great question.
Wonderful, thank you. We will. So yes, if you'd like more information, another question that's come here is it possible to share the slide deck at all? So that's something that I'll put to you. If there are questions that we don't get to here, because it is such a fulsome topic for discussion, we will put together an e-bite, and we'll invite both Laura and Anna to contribute to that as well. Alrighty, I have another question here. I work in a disability facility, and several residents have been placed on thick fluids because of oropharyngeal dysphagia. They've had an assessment by their speech pathologists, and I'm wondering how accurate you have to be when preparing the fluid. Should the fluid be measured in a measuring cup before adding the thickener?
Yeah, I mean, it's such an important topic, isn't it? And we're lucky that we have the IDDSI flow test. So if we're feeling really confident that a good instrumental assessment's been done and that the recommendation is sound on the thickness that resident is safest at, then using the IDDSI flow test is the perfect way of checking those fluids. And you don't need to use the IDDSI flow test every single time you do it. If they've got a favorite drink and it's naturally thickened and it's a mango juice or something, and you've tested it once, and you're giving it to them straight from the fridge every time, you don't need to test it every time you do it. You test it the once and then you're done. But if you're not sure about what's in the cup, the flow test's the quickest way of doing it. But our industry has also tried really hard to help us with this. The pre-packaged drinks are all controlled already and tested for us, and so are the portion sizes that come out of the company's pump bottles or their scoop cups. So no, you don't need to test them as long as the method you're using has been tested already on the drink that you are giving that resident that day.
And something just to add to that is IDDSI accounted for all of these variabilities in their ranges. So the flow test wasn't, I hope I'm speaking correctly, this is what was told to me in the beginning, that it wasn't intended to be mixed to 5.2 ml. They have the range, the 0 to 1, the 1 to 4, the 4 to 8, the 8 to 10, to account for all of those variabilities.
Yeah, that's exactly right.
Yeah.
Sorry,
exactly.
Anna, was there something else you wanted to add?
No, I was just going to agree that, yeah, exactly. That's the point, that you can feel confident within that range.
Sure. We have probably time for one last question. So we've got here, love the research direction towards silent aspiration versus aspiration that you presented. 5 mils is a fairly small bolus and 50 mils is quite large. And the person is wondering, did the 50 mil involve sequential swallowing? And was there any data, for example, on a 20 to 30 mil bolus, or was volume effect assessed?
No, we didn't do any interim. We just did teaspoons. So the 5 mils a teaspoon and then straight to the cup for sequential drinking. Exactly. And if you're interested in sequential drinking, we've got quite a few papers coming out on that topic with Kendria Garan's group. I'm really interested in sequential swallowing. I think it's a hugely important stress test in adults. It's obviously how all infants feed sequentially, and I'm not very keen on controlled volumes when I'm actually looking at natural drinking, because I think that's not what we do. So we're doing a lot more research in sequential swallowing, but no, I think you will always get a difference in response to aspiration depending on volume of aspiration, and therefore volume is going to be dependent. So the larger the sip, and we see that in our patients at bedside, we give them a big drink. They did fine on the teaspoons, we give them a large drink, is the entire premise of the Yale protocol. You force them to take so much that anyone with dysphagia will eventually react. So yeah, I think you're quite right. Response is going to be volume dependent.
And Laura, yes, the importance of that sequential swallowing for infants, obviously, and
Yes.
and I like the way you spoke about that too.
Yes, thank you for mentioning that. And so for infants who have to sequence suck, swallow, breathe every second, suck, swallow, breathe every second, and they're feeding for 20 minutes. So you have this tiny little slice in time to do a video fluoroscopic swallow study that will change the course of this patient's life. So, you know, we just have to take all of it into account, that it's very, very challenging. Swallowing is very challenging, which is why we're all here.
Yeah. Exactly. Alan, so just before you finish up, I would like to sincerely thank Dr. Anna Miles and Dr. Laura Brookes for their wonderful presentation and the opportunity to discuss this hot topic. We do have a lot of research still to do in this area to contribute to that literature base so that we can keep doing the very best we can for our patients. Alan, I'll pass over to you.
Thank you so much, Dr. Caro, Laura Brookes, and Anna Miles for being here with us today. Thank you for sharing your expertise with us, with the IDDSI community around the world. And a reminder that the recording will be available on our YouTube channel shortly. We will get the slides from our panelists and share those along with their email addresses so that you can get in touch with them. And we're going to leave it there. Thank you very much. Have a lovely evening, morning, or afternoon, wherever you are. And until next time, thank you very much.
Thank you so much.
Bye.